that you will use the chat feature. We want to hear from you. Have a question, send it in the chat feature. Presentations will be recorded and shared. PowerPoints will be shared as well. And we ask that you both enjoy and evaluate today's presentation. And also, if you need Spanish interpretation, there is a separate call-in line, even though you can still say on this Zoom platform. And those, both the phone number and the meeting ID is at the top of the chat feature. But if you cannot scroll that far, the phone number is 929-205-6099. And the meeting ID is 987-833-98784#. And for us freedom fighters, hashtag. So we welcome you to today's presentation on telehealth community-based providers embracing a new space, which will go until a few minutes before 2 p.m. And then we'll reconvene for our closing session, and I'll post that link at the end of this session. So after completing this workshop, the participants will be able to understand telehealth and the 4 most common telehealth strategies. Participants will be able to understand the 4 most common barriers to telehealth and ways to overcome them. Today, we have sharing on this topic, telehealth, community-based providers embracing a new space, Mr. Billy Sample, who is Telehealth Resource Center Program Manager, Medical Advocacy and Outreach. And we ask that you all will welcome Mr. Billy Sample.
Good afternoon. I appreciate everyone taking the time out of their busy Friday to sit in and listen to a little bit of information in regards to telehealth. I've titled this presentation, Transitioning to Telehealth, Simple Tips for a Successful Transition from In-Person Based Care to Telehealth Care. And please understand that this can be any form of healthcare necessary. So it could be your direct practice care from provider to client, or it could include any of the ancillary services that your organization offers, such as behavioral health, social support, housing, translation services. All of these different services that your organizations provide can generally make a seamless transition to telehealth. And with that, we'll go ahead and get into the presentation. Next slide. So before we can truly understand how to deploy telehealth, we need to know what it truly is. And so as you guys can see on this slide, there is a beautiful definition from HRSA that is very wordy. And it says that it is the use of electronic information and telecommunications technologies to support long-distance clinical healthcare, patient and professional health-related education, public health, and health administration. So that is how HRSA defines it. I define it, simply put, telehealth is a way of having a patient encounter without the need of the patient or the provider to be in the same room. Telehealth even offers us the solution to the problem of the provider and the patient not being available at the same time. Next slide, please. So our first objective is to understand the 4 most common telehealth delivery models. And these are those 4 models listed here. The first one is live video, which is a 2-way live video and audio streaming session in which the provider and the patient would interact in real time. The second delivery model is what is known as mobile health. And this is where a patient sends information through the use of a mobile device. So this is like when we would transmit our dietary information through the use of a phone app, or when we have a smartwatch that monitors our exercise and shares it with your provider team. Many of you may have heard that a lot of the sports teams are utilizing these monitors to evaluate their players' dietary and their activity levels. And it's even caused some stirs in the NCAA as a way of monitoring that wasn't allowed as a response to COVID-19. The third way is through what is known as remote monitoring. And this is where a patient would wear a medical device that reports medical information for a provider to monitor. This includes things as invasive as live video streaming of a patient's hospital room, or something as benign as when you open a pill bottle and it transmits that you have opened your pill bottle to your provider team. And then the fourth most common model is known as store and forward. And this is where a medical team or a client can transmit review records, images, and pre-record video for use at a later time through the means of store transmission and communication. This is most commonly done through patient portals. So your electronic medical record may have a patient portal where you can upload records, you can upload images, you can upload pre-recorded audio or pre-recorded video. Some of them have that full capability. And that's where you can actually address the provider and the client not being available at the same time. Next slide, please. Another one of our major topics was to discuss the telehealth delivery concerns. When we talked about the four most common telehealth delivery concerns, one of the biggest and most important concerns was privacy, or the protection of the patient information. Another topic was, how do we do telehealth if we don't have an IT team? And then the third one, which encompasses number 3 and number 4, is, as a provider or a provider team, how do I effectively transition? But also as a client, how do I effectively prepare for my healthcare to change to telehealth versus in person? And so those are the 4 topics we're going to discuss today as far as the transitioning. So the first one, perfect, you were right there. Good job, Sean. The protection of patient information is paramount. And so this is that HIPAA compliance piece. And it says that ensuring the delivery of a private, encrypted, HIPAA compliant telehealth consultation is paramount. This gives both the provider team and the patient peace of mind to know that their information is being protected. So for our provider teams and for our clients, it's very important to know, as a provider team, when selecting a telehealth vendor, you need to ensure that they are willing to sign a business associate agreement for the purpose of protecting PHI, which is that patient health information. The BAA makes the telehealth provider and the telehealth vendor both liable for a breach. It's very important as a client that you ask your provider team, do you have a BAA on file with your telehealth vendor? Is my PHI protected? When selecting a telehealth platform, you must also ensure that both the video and the audio are encrypted end to end, meaning from the device that is transmitting to the device that is receiving. There are platforms out there that only encrypt audio, There are also platforms out there that only encrypt video and don't do both. There are also platforms out there that encrypt audio and video, but only from the source to the server, which is their cloud. And so you want to make sure that you select audio and video encrypted end to end, and both audio and video are fully encrypted. And I know that was a mouthful. Next slide, please. Understand, as a response to COVID-19, there has currently been a relaxation of HIPAA compliance enforcement regulations for the use of video platforms during this COVID-19 response. This allows for the use of any non-public facing video platform to be used for the purposes of telehealth. You may hear of providers using FaceTime, or using Facebook video, or any of those other non-public facing video platforms that provide connectivity. This relaxation only applies to the use of video, and all other HIPAA compliance regulations remain in place. The relaxation states that they will not prosecute medical organizations for breaches of security when a good faith effort has been made. And that means that a provider has tried every other means of communication with their client, and this was the only option that they had left. It says that they will selectively prosecute. So that gray area always gives me cause for concern. I don't want to be the one that they selectively choose to prosecute. So my recommendations to everyone transitioning into telehealth is that you ensure that you build your program on the original HIPAA requirements, so that you don't have to make changes to your program when the relaxation period is over. It is better to build it to the more strict regulations than to the relaxed regulations, so that when we start to experience our new normal and they take away these relaxations, you don't have to retrain your staff, and you also don't have to retrain your clients. Next slide, please. So the next major issue that we were experiencing with people that were asking about telehealth is, I don't have an IT team on staff, or I don't have many IT people on staff. How can I go to telehealth? And so there are a couple of different ways that telehealth is administered. You have hardware, where you have actually telehealth carts, and you have software, which is something that we're using right now. Zoom is a software-based telehealth solution. And then you also have a blended environment that incorporates both. And so let's talk about these different methods. So hardware-based telehealth solutions usually have a larger upfront cost, and they tend to require a robust IT infrastructure to be able to effectively utilize them. Now, this can be very daunting for organizations that have a small IT organization or a small IT shop. Please understand that most vendors that you buy your equipment from have teams that can help you with configuration, they can help you with setup, and that they, other than system software upgrades, the equipment is usually self-sustaining. So once you get them to originally set it up, there's usually not a whole lot you have to do to them. You can also purchase service contracts that will help you with equipment failures and be able to help you set up replacement equipment should something go wrong. Next slide, please. Software-based solutions, they're usually less invasive when it comes to your IT needs, and they can usually cost you far less. The drawback to that is that you'll always be paying for a subscription for service, and you'll never truly own anything. A lot of organizations are shifting to telehealth through grants, and there are grants out there that do not pay for software. So please understand that a software-based solution may not be applicable if you are using grant funding for your telehealth solution. While these software-based solutions are easier to deploy, they also have the limitations of oversight. These solutions are cloud-based, and should the cloud-based hosting system be down, your telehealth system will be down. When we first all shifted to most people working from home, there were a lot of these major platforms that continued to crash. And it was because their cloud-based hosting system was down and people couldn't access the video platform that they were trying to use for meetings, conferences, and for telehealth. Organizations with a small IT team or organizations looking for a temporary telehealth solution most likely would deploy this telehealth model, which is a software-based solution. Next slide, please. So organizations that have the most versatile and effective telehealth delivery system have found a way to deliver a blended solution. This is using both a software and a hardware-based telehealth solution to deliver care to virtually anywhere. For example, Poly, formerly known as Polycom, now has devices that are shipping that both have their Polycom infrastructure on them as well as Zoom infrastructure on them. And so you can buy a hardware-based telehealth unit for clinical settings with Zoom on it and use software-based Zoom, and those two devices will communicate. And that's what is called a blended delivery model. So what this does is this would allow you to deploy a software-based solution immediately to get telehealth out to the field right now, and then you could build on that to implement carts and peripherals to build a complex and robust telehealth system. MAO, the organization that I work for, we are a Poly shop or a Polycom shop, and we have a Polycom hardware-based solution and software-based solution. And when the COVID-19 response came to Alabama and we had to make the decisions to stop bringing our clients in, we were able to take our 2,200 clients and move them from in-person care to being able to do it through telehealth at no cost because we invested in a blended solution from the beginning. Next slide, please. So the next topic that we'll talk about is preparing for the transition from in-person care to telehealth services, and this is from a provider group perspective. So we use the CHARTS acronym as we have developed a way of implementing telehealth with teams all across the country. And the first part is C. This is coordinate with all service partners and staff to discuss the telehealth delivery objectives. So asking the questions, what do we want to do with our telehealth system and how do we get there? So that's the first thing, is to coordinate and discuss your objectives. The H stands for hosting meetings to discuss the concerns and objections and have open and honest dialogue. This needs to happen from the provider team to your patient champions. You need to have patients involved in this process so that they can help you cater your telehealth delivery solution to what is most effective to your clients. A, assemble a team of champions to include patients that will ensure the success of your telehealth program. If you put a provider that has zero desire to shift to telehealth as your telehealth champion, the program will fail. If you have a provider that is excited about telehealth and you make them your champion, your program will succeed. Next slide, please. So the next letter is R, and this is all about rehearsing. Rehearse, rehearse, rehearse. Practicing with your peripherals and the transitions between those peripherals to live video, to the websites needed, is very important for a fluid telehealth encounter. If it looks like you've been doing this for 100 years to your patients, they will have nothing but confidence in your program. And the only way for you to do that is to practice. So the next one is T, and that's for training. You need to train everyone to be able to access all of the websites, place the calls, and utilize the peripherals. So if your normal telehealth champions are out, the consultations can continue by just putting someone in their place. We at MAO experienced the fact that life happens and sometimes providers can't be in front of a telehealth unit. And by ensuring that all of our providers were trained on telehealth, we didn't have to reschedule our patient appointments because we could just put a different provider in front. And with the electronic medical records, the providers were able to stay very educated on our clients and their cases, and it actually created a seamless transition from one provider to the next. And then the last of the acronym is S, and that is solicit feedback. It's very important that you solicit feedback from your team and your patients. You need to celebrate what you're doing effectively and change what you are struggling with. But most important, you have to be open to receiving the feedback and making the necessary changes in order for your program to move forward. Next slide, please. So this is very small, and please forgive me. As you all see, I have glasses on, so you may see me lean much closer to the to my laptop screen to be able to read it. But this was a single page tip sheet that I made for us to be able to provide to all of our clients as far as what do they need to do to prepare for a telehealth solution versus an in-person solution. And so there are 10 points. And the first one that I have is privacy. So privacy is a major concern. Please ensure that you are in a place where you feel safe and private to share your health information conversation. Use headphones as opposed to a speakerphone to help keep your information private. Lighting. It's very important to ensure that the room that you're in has adequate lighting. The advantage of a video call is to be able to see the participants, so making sure that you have good light and enough light is important. I actually moved around 4 different places in my apartment today to find where I felt I had good enough lighting that it didn't look bad. The next one is power. Ensure that the device that you're using for your telecare/telehealth call is charged. Video calls use battery power, so make sure that your battery isn't low when it's time for your call. No one benefits from a dead battery. The next one is Wi-Fi. Please understand that video calls could use up to as much as a half a gig of data for a 30-minute call. Connect to Wi-Fi if at all possible. This will ensure a good data connection. If Wi-Fi isn't available, please know that 4G will absolutely handle your call and you should be able to see and hear with minimal issues. But know that it takes data. So you'll either need to have a device with a data plan or Wi-Fi available in order to do your video call. Apps. Some telecare/telehealth services require the use of an app on your phone or your tablet or an applet on your computer. Download these in advance of your appointment so that you can be prepared prior to your appointment time. The organizers of this meeting absolutely took part in that. They sent me an email saying, hey, make sure that you log in about 15 minutes early so we can make sure that if you run into any issues with your audio or video, we can fix it before meeting time. And I certainly advocate for that. Be early. Most telehealth/telecare video rooms are open at least 10 minutes prior to your appointment to allow you to make sure that there are no issues. take advantage of that time. So if you have problems, you can engage the staff to help you. Point of contact. Ensure that you have the contact information with you for your point of contact at the agency you're talking to. Knowing who to call and how to reach them if you have trouble is very important. Act normal. Telecare/telehealth is as good a care, if not better, as you would receive in person. Act like you're face-to-face with the person on the other end. You don't have to talk louder than normal. You don't have to hold the device right to your face, and you don't have to put on a front. The providers are here to make this as easy as possible. Relax and enjoy the next evolution in your care. Tested platform. Please understand that telehealth is not new. This technology has been used for at least the last 10 years. The response to COVID-19 has just allowed people to find additional ways to utilize technology to keep us all safe. Feel comfortable and confident in the fact that you're receiving great care in an exciting, new to you way. And last but not least, tell your circle. Let everyone in your circle know how good it is. The care is great and the delivery model is great. Let the people in your circle know how you benefited from this delivery model and how much you liked it. Some people will be hesitant. Let them know your successes so they may have successes of their own. Next slide, please. So I've talked a lot about what telehealth is and how to do it, how to transition. This is probably the slide that I am the most proud of. This is pre-COVID-19 data, and this is the successes from my agency's telehealth program. So our agency has somewhere close to 2,100 patients. And when we look at this data, all of our patients that received care at MAO, 76% of them were retained in care. 88% of all of our patients used their antiretroviral therapy, and 75% had a suppressed viral load. When I segment out our patients that received their care through telemedicine and not in-person services, 96% of those patients were retained in care. That is a 20% increase in retention. 97% used their antiretroviral therapy. That is almost a 10% increase in drug adherence. And 93% of those patients had a suppressed viral load. That is staggering. That is an 18% increase. The most amazing part of this data was the fact that there was over a 96% satisfaction rate in people being happy with their telehealth care, and the providers were the same. So there wasn't this one special provider that was doing all of this amazing stuff. All of our providers use telehealth, and this is across all of our telehealth patients. And so not only have we shown that you can do it, but you can also see how effective it can be. Next slide, please. My job with MAO as the Telehealth Resource Center Program Manager is to train people on how to implement telehealth. This is my contact information. If your organization is looking to shift to telehealth and isn't sure where to go or isn't sure the right questions to ask, feel free to call me and feel free to email me, and I will be happy to help you guys prepare for the transition, to ask the right questions, and to select a sustainable telehealth model that would be effective for you all. And with that, that's the end of my presentation. The next slide is just a question slide. I've been seeing a lot of questions sort of pop up as the chat box sort of pops up. So that's exciting. And I am prepared to be put on the hot seat for the Q&A.
Right. So we appreciate your wealth of knowledge, Mr. Sample, as you relay this important information for those of us who might be considering telehealth as an option for our agencies. As you have noticed, there are a lot of conversation in the chat, and the first question comes from Lee Dukes, who says, I want to know if this is going to be the new norm, talking about being distance because I am really on the fence because I love face-to-face interactions.
So I think that is a great question. And my response is, I don't think that telehealth is going to replace in-person care. I think it's just going to be another delivery model that can be advantageous for organizations to use when in-person care isn't fiscally or morally the responsible way to do it. So we owe our clients an obligation to keep them as safe as possible. And I simply think that telecare and telehealth offer us another way to provide telehealth and healthcare services and keep them safe. So is it going away? I don't think so. I don't think they'll close Pandora's box, but I don't think that it will ever replace in-person care, because our providers are amazing. Thankfully, telehealth will translate that, but there's just something to be said for in-person care when it's applicable.
Next question. In your presentation, you talked about clinical settings as it relates to telehealth. Can you give us a definition of what clinical setting is?
So there are a couple of different ways that we provide telehealth at MAO and ways that I advise people to provide telehealth. You may put a telehealth cart in an exam room, and that exam room becomes a dual purpose exam room. So it could be used for in-person patient care, but it also could be used for telehealth care if your provider is distant. You don't have to go through and reschedule a bunch of things if your provider needs to work from home for the day, because you have the opportunity of being able to use that same exam room that your client is comfortable coming into. They just see their provider via a video rather than in person. Another thing that we do is we actually have telehealth spaces, which are specifically designed for those ancillary services to keep the exam rooms opened up if necessary. We have a few offices within our agency where a patient can, or a client can go in for social services or can go in for behavioral health, because our social workers and our behavioral health therapists are spread all across our coverage area. And so we don't have to bring a client all the way into Montgomery or to Dothan to be able to receive those services. They can go to the closest location that we have telehealth at, and can receive the same services they would if they went in person all the way. And that's sort of the way that we used it prior to the COVID-19 response. The state of Alabama has an interesting dynamic that it doesn't allow a patient's home to be an originating site. And so we had to find ways of really creating additional spaces for clients and still being able to find reimbursement for that. Right now with COVID-19, the insurers are allowing us to provide service from a client's home. I'm not sure if that's going to continue post-COVID-19 pandemic. And so we will go back to bringing them to the closest location that we can get them to provide them those services.
Our next question, thank you, comes from Juan Carlos Vega. And there's a follow-up question to this, but I'll ask Juan's first. It says, for telehealth to work, the patient needs, one, an internet connection speed needed for videos, Zoom use, and upload documents on patient portals. Two, patient has the equipment upgrades to operate apps and websites. And three, the patients have the 21st century skills to turn on the video. As a librarian, I see many folks, mostly poor, non-English speakers, and folks of color lack the technical skills and might be intimidated to operate these systems. Are there any thoughts on how to manage these issues?
So yes, there are a couple of thoughts. Please understand that telehealth is just another tool in our arsenal. We have a huge arsenal to address the HIV epidemic that is plaguing this nation, and telehealth is another tool. I would say that a effective solution for that, if in-person care isn't an effective solution, sending someone to the client to help them get that set up whether it's we bring the device to them and we put it in a call and hand it to the client or consumer, or we provide them the technology necessary, because there are grants out there that would help us get these devices into our clients' hands. And so I completely understand and completely concur that there are going to be a patient segmentation that telehealth may not be the answer for. I will also challenge you and say that when we first went to a fully telehealth model, we got a lot of pushback saying that they wouldn't know how to do it. I am very excited to say that that is the exception now and not the norm. And so when given the challenges and teaching them how to overcome, we have seen a lot of patients become more engaged in their healthcare because of a video platform. So I know that kind of talks around your question, but I think it provides a lot of great ways of addressing that question and saying that, yeah, you're right, there are going to be people that can't do this. But I think that we can come up with many solutions to be able to provide either the technology if they don't have it, or send somebody out to them, their social worker, a translator, you know, those sort of things, to be able to be there and be with them in their environment.
Yeah. So Guadalupe Joyner adds to Juan's point about the issue of equity more so in rural areas. Ruben's question as a follow-up to Juan's question, and you might have given some answer to it, but I want to ask it, this is a follow-up to Juan's excellent question. What video chat apps can be downloaded and utilized by clients with limited data in their phones, and are those who use Obama phones or assurance phones?
Okay, so government issued phones, unfortunately, they don't have data plans, or they have such a low amount of data that it is ineffective. So there's a couple of different things that we can do. For people that have those government issued cell phones, I would challenge you to look for grants out there to upgrade their devices, or put a device in their hands that has cellular service or data service. You could host pop-up clinics where you take a Verizon hotspot and they can tether their phone to that Verizon hotspot and be able to have a video call. And those people who have lower data plans, used to, the biggest problem with telehealth was the amount of data consumption. Understand that these apps that we're using now actually use so much less data than they did in the past. And a lot of conversations can be done in 10 to 15 minutes. It doesn't necessarily need a full 30-minute consultation. So there are ways around it. The platform or the apps to use, there are a lot of them. There's Doxy.me, there's Zoom, there's Polycom Real Presence Mobile. There are a lot of platforms out there that can be used for it. The one thing that I will remind you is, as you start vetting out these solutions, go back to that HIPAA compliance slides that I had, and make sure that they'll sign a BAA for the protection of PHI, and make sure that those platforms offer encrypted end-to-end audio and video. There are a lot of people out there that are jumping into the telehealth game from a service provider standpoint, as far as providing those apps, and they may not necessarily have everyone's best interest at heart. They may be making those decisions based on a financial windfall. So I would say that those are probably my ways of addressing those objections.
Thank you. Our next question is from Angel Fabian, who thanks you for your presentation. And then ask, we have heard from some health provider meetings that some systems do not allow for simultaneous interpretation. Any thoughts around this potential barrier to access to care?
So I would tell you that most systems will allow 3 people in a conversation, very similar to what we see now, where there are a multitude of us in this single conversation. And yes, it will take a little more time for somebody who is non-English speaking to see an English speaking provider, or somebody who needs translation services. but using something that allows for multi-point, which is more than two connections to concur at the same time, would be your solution to that. And simply having a translator available like we have on this call today.
Thank you. Our next question is from Erica Mendez, who says, is there another possibility to deliver care in emergency situations for people in need when telehealth is not possibility duo to the absence of local internet access? Sometimes small communities do not have great internet access or no access at all. How to guide people in this situation?
So understand that right now, sometimes a telephone is our best solution. You know, talking to a provider through a phone call sometimes is the only way that we can actually keep that connection. I would say that that would be the exception and not the norm. Being from Alabama, we cover a lot of rural counties. And so I completely get it. But getting cellular service in those locations sometimes is the solution to that. There's a Gen 5 satellite that's out there that you can actually get broadband connections from a satellite. And yeah, there's still some areas that can't get that as well. I get it. I completely get it. And for those situations, we just have to stick with the tried and trusty telephone that we have. I mean, sometimes that's just the only thing we have. Or even in some of those even more rarer cases, we may have to send the provider team out there. I mean, that just may be what is the most morally responsible thing for us to do. And so sometimes we have to make those choices. But again, telehealth is simply another tool in the arsenal. It is not the only tool.
Yeah. And I want to add this comment from Miguel Angel Rosa Rubio, who works as a Plus Care coordinator at the Family Services Center of New York. He adds that the Department of Health here in New York State is implementing new protocols and guidelines to establish this as a part of clinical care. However, there are still challenges with internet access, especially with patients in low source of income, housing limitations, health conditions, and other socio-demographic issues. It is a long road to ride to completely implement this strategy. Thank you for that comment.
I think it's exciting to know that because of COVID-19, if there is any positive to come out of it, it is the fact that internet access needs to be available for all. And there's been a lot of people that have discussed that, but it's never truly been on a national platform. And I think COVID-19 truly exposed a lot of the deficiencies that we had in nationwide infrastructure. And so I think that may be, as I like to call it, the blessing in the thorn, is the fact that we may see a much more aggressive strategy in being able to get broadband to everyone. And so we may be able to resolve some of these lack of internet access situations due to, this pandemic.
Right. Our next question comes from Dr. Aurora Kim Paradises, and excuse me if I incorrectly said your name. And their question is, how many of the approximately 1,200 clients were managed on telehealth care?
So we have always segmented out at least 25%. For that segment of care, it was 33% of our patients. And please remember that it was almost a 2,000 patient segmentation and not 1,200. So it's almost 33% of those patients.
Okay. And from Daniel Ravillo, ask, is a telehealth session recorded, stored? Why? Is it required by law to store it? A face-to-face medical visit is not recorded. Why a telehealth session should? Talking about the interaction, not writing down the visit summary.
Okay, so no, any telehealth consultation should never be recorded. That is a direct violation of HIPAA guidelines. So is there capability for that? Absolutely. We're recording this session right now. So if you use Zoom for telehealth, there is that possibility of it. But no, it should not be recorded or stored for any purposes or any reasons. If you want to use a store and forward method where a provider would pre-record on video a set of 10 to 15 questions and send that via patient portal to a client, and then a client may respond with their own answers. That's not a real interactive telehealth session. And so, that is something that is fully consented by both the provider and the client. But as far as a real-time, live, two-way interactive consultation, it should never be recorded.
Thank you. Both Karen Mortka and Kevin Ramos says that your presentation was excellent and outstanding. Karen adds, can we go back to your contact information? And I did. And then her next question was, have you used telehealth for patient support groups?
Absolutely. So we are currently, we have several support groups. One of them currently right now, especially with, the stigma associated with HIV and the isolation that a lot of our clients felt has only been compounded by the isolation that's sort of been forced upon them as a response to COVID-19. And so we have created a behavioral health support group that meets every Thursday on our platform, and we are able to bring in our behavioral health team and a group of clients that are willing to disclose their status to other clients and have those support group conversations. I will tell you, other than a few medical procedures, anything that you can do in person can be supported through the use of the proper telehealth platform. And if you guys are interested in understanding what platforms are out there that would allow for that, please send me an email and I will respond as I can and help everyone kind of guide through that and selecting the right platform for what you want to do. But it's important, before you email me, talk about what your objectives are so that we can formulate the best solution for all of your objectives rather than just one.
And I will add to that, if they're sending you email questions to CC, there was a confirmation for this Zoom, and it says, if you have questions, use this email address. CC us on those questions as well, because what we're doing is we are compiling a list of questions, and then we'll get the answers from the presenters, and then we'll share those answers widely with everyone.
Absolutely.
Personal, so that everyone can have access to the questions and answers as well. We have a question from Kevin Aiken that says, not everyone has the funds to have a computer or a smartphone. Is there software those individuals can get assistance to get the necessary equipment to have the capacity to do telehealth, or are they just out of luck?
So I guess my question would be, and if you're still here, if you can answer in the chat box real quick, are you talking about from a client's perspective or a provider's perspective?
Okay. And while we're waiting for that answer, we'll go on to another question. This is from JML that says, can a session be recorded if a provider is participating in a training? Example, psychology and evidence-based therapy training program, to share a recording with their supervisor.
So again, your best friend in that is consent. And so getting a client to sign off on the recording is first and foremost, and then ensuring that you keep that consultation protected at all times. So it should never go on a flash drive. We should never email it to anyone, that sort of thing. So yes, if you get consent, it could be recorded for training purposes. But again, it's all about consent. And then it's all about you now, because you have that recorded, you are now bound to keep it private. And so making sure that only those with a need to know are able to view it. And once the viewing is over, then delete it, get rid of it, that sort of thing. I would not compile it for posterity's sake at all.
Right. And Kevin did answer. He says, from a client perspective, but to follow up on the question, it says, Is there assistance to get necessary equipment to have the capability to do telehealth, or are they just out of luck? And from a client's perspective.
So I think the burden of helping your clients out ends up being on the providers. You guys would have better access to the grants than the clients would. And so getting those devices into the client's hands, I think truly falls on the provider team finding the right grant. There are a ton of grants out there that you guys could use, especially the FCC grant for the COVID-19 response. That is an amazing grant, and there's still a lot of money still available out there for that. So I would highly recommend looking at some grants, looking at HRSA grants, looking at AIDS Foundation grants, things of that nature. And then as far as the cost of apps, that burden, again, is felt 100% by the provider team. The downloading from the client's perspective is completely free. They wouldn't pay anything to be able to download them. The apps are free. They just have to have data.
Okay. And I do want to do a time check. We are 5 minutes away, and we have 2 more questions. So this question is from Miguel again, that says, is there any changes in billing to insurance using telehealth? And what's the cost effective for health facilities or agencies providing care services?
Okay, so this one is kind of a moving target. We continue to see things change every day in regards to telehealth and telehealth billing. I would tell you that if you look it up today, there's some amazing resources out there. The National Telehealth Resource Center has some great information, and you can actually drill down by state to be able to see what the reimbursement is. As far as the advantages, I will tell you that I am partnering with an organization out of South Carolina that was getting reimbursed $25 per telephone call, being able to talk to each one of their clients. I helped them move into a telehealth platform that is costing them about $750 a month. And they went from 87 phone consults a week to 87 video consults a week. And the reimbursement was $25 for phone and $65 for video. So if you guys want to do the math on what $40 more per visit on 87 visits a week would be for your organization, you can see, I think it's about $3,200 a week more that they were getting, or maybe a little bit more than that, just by shifting to a platform that cost them $750 a month. So there are some wonderful advantages. And again, a lot of the insurance companies responded to COVID-19. It'll be interesting to see the reimbursement piece once the response has kind of ratcheted down a little.
All right. And our last question comes from Sophia Mayano Kleshner, that asks, health literacy has been an issue through face-to-face services. How is that managed with telehealth?
The exact same interactivity and health education that you deal with from a face-to-face encounter is the same via video. I think the benefit is for some of our clients who need that support structure at home, by engaging those clients at home through the use of video, we're able to engage their support structure as well. And so there tends to be a small uptick in the health literacy. I know through the use of some of the peripherals, clients being able to hear their own heartbeat, see an EKG on the screen. We use an exam camera where we can actually examine their ear, and they're able to see their eardrum for the first time. Some of those moments, those aha moments of, wow, this is amazing, actually get them more engaged. And so I would say that it's not the answer to everything. And those same challenges are going to be experienced through telecare that they are through in-person care. I would like to say that the care is the same, if not better. So those same challenges that you experience in person, you're going to experience via telecare.
Okay. And we have one more question, and the other folks asked, can we please ask this questions? You talked about available grants that might be, a grant that might be available. Can you share examples of these grants?
So I would look at the Mac AIDS Foundation. I would look at the Elton John Foundation. I would look at HRSA grants. I would look at the FCC grant. There are some great grants out there from the FCC. The Healthcare Connect Fund is one. The COVID-19 response, or the COVID-19 telehealth response grant is another. There are some great grants out there. What I can do is, if an email is sent to me with that question, the first couple of days next week, I can kind of compile a list of a few grant sources that you could go to. There are a lot of drug companies out there, medication companies out there that are offering telehealth grants right now. Gilead, BMS, Bristol Myers Squibb. I mean, there's a lot of grant avenues for you to approach. Also, when selecting a vendor, they usually have grants teams as well and would be able to help you out with that. One grant that I definitely want everyone to put on their radar is a grant that is opened up generally twice a year, and it is the RUS DLT grant. It is a distance learning and telemedicine grant, and they offer two. It's definitely for rural areas. So those of you that have concerns with rurality, very, very important. So use the RUS DLT grant, but they also opened a second window for those people that were addressing the opioid crisis. And so if you have a opioid response in your practice, you could look at that grant as well. Two different components. You can actually apply for both of them and receive awards on both of them and be able to truly impact telehealth in the rural areas.
All right. So